Good morning. Good morning and welcome to the last Transplant Rounds of the season, which is also the third ever Linda Wright lecture. I'm Jed Gross from UHN's Bioethics program, where my work supports the activity of the Ajmera Transplant Center. The purpose of the named lecture series is to honor our former director of bioethics, Linda Wright, by continuing to explore timely ethical issues in transplant medicine. Linda took an interest in organ replacement while working as a clinician in Montreal and went on to build up the bioethics program at Toronto General Hospital and UHN as we became a center of transplant innovation. We're fortunate to have her in the audience today. We're also fortunate this year to be able to hear from Keren Ladin, who directs the Reach Lab at Tufts University in Massachusetts. It's one of the paradoxes of our time that even as local activities are operating at reduced capacity, people are creatively using technology to bridge physical distances as never before. Dr. Ladin's scholarship brings a keen eye to the interactions among patients' social circumstances, listing and allocation practices, and ethical principles. Her work touches on some recurring problems in healthcare delivery, such as the desirability of rules versus standards, the significance of absolute versus relative disadvantage, and tensions between duties to individual patients and to the public. But she's approached these questions in a way that breaks fresh ground in the transplant context. She's also especially well positioned to cast a comparative light on our experiences as chair of the U.S. Organ Procurement and Transplant Network's Ethics Committee. Without further introduction, Keren, we're eager to hear what you have to say.
Thanks so much, Jed. What a lovely and generous introduction. And thank you for inviting me. It's such a pleasure to be here. I'm going to try to share my screen. Sorry, just one moment here. Okay. Can everyone see that okay? I'm going to assume yes, unless I hear otherwise. It's such a privilege to be here. Thank you. And today I'm going to talk a little bit about some recent work that we've been doing in our lab, which is a continuation of a line of research looking at the use of subjective criteria and assessments in transplant listing. And in particular, I want to spend some time on the role of implicit bias in the evaluation and listing decisions for transplant candidates. And you'll see that this work relates nicely to some recent work that we've done through the ethics committee of the OPTN to evaluate some of the criteria that listing candidates, that transplant candidates encounter when they embark on their transplant evaluation process. So I serve as the chair of the OPTN and UNOS Ethics Committee and receive research funding from PCORI, the NIH, and the Greenwall Foundation, but the views expressed here are my own and do not represent any other organizations, and I have no other disclosures. And as I said, I'll spend some time on identifying subjective judgments and implicit biases. You'll be able to recognize how they're used in their potential to include value judgments, social value judgments. And then I'll talk a little bit about some opportunities to mitigate bias in transplant listing decisions. All right. So I'll just start off with a backdrop that in the United States, and I think in Canada as well, racial and ethnic disparities, socioeconomic disparities that are faced by Indigenous populations are pervasive and persistent. And despite efforts over the past 30 years in the transplant community to mitigate disparities, they persist in large part due to barriers to access to transplantation. And I'll just very, very briefly review. These are some of the newer studies. But this study here that was recently published demonstrates that the likelihood of a Black person in the United States to receive a candidate compared to a non-Hispanic white person is 0.74 for a kidney transplant, 0.49 for a living donor kidney transplant and 0.9 for a deceased donor transplant. And this was a very interesting study that tried to assess a little bit why that is, what are the root causes of these disparities. And they identified a number of factors, including older age, lower income, less social support, higher reliance on public insurance, greater comorbidities, and less transplant knowledge, among other factors. In this study, which has taken a new approach to try to understand how likely it is that candidates have access to transplantation compared to the need for transplantation, so looking again at the gap in access, they compared non-Hispanic Black patients, non-Hispanic white patients, and Hispanic patients in terms of their prevalence of liver failure, and then their ability to be listed ultimately for a liver transplant. And they found that non-Hispanic Black patients were underrepresented at 81% of the centers that were included in this study. Non-Hispanic white patients were overrepresented at 58% of the centers, and Hispanic patients also remained underrepresented at 62% of the centers. And so today, I want to focus on, instead of organ allocation rules and kind of how we try to mitigate disparities once somebody is on the waiting list, I want to focus on this larger part of the funnel. So really thinking about the number of people who ultimately get to this bottom piece of receiving a transplant and looking at transplant outcomes is quite small compared to the burden of disease and disproportionate inability to access transplantation, which affects a far larger population. And that can really be thought of in three different strata. So the first is differential risk or likelihood of developing organ failure and the burden of organ failure by race, ethnicity, socioeconomic status, gender, geography, language, and disability status. Subsequently, looking at the gap between those who've developed organ failure and those who are referred to a transplant center for access. And in that category, really trying to disentangle what are some of the challenges that lead somebody who is referred to not be listed. So inability to complete the evaluation process or to start the evaluation process, or disparities in listing decisions. So these three top pieces are what I will focus on today, and they're really largely affected by implicit bias, as you will soon see. So again, the steps of the transplant process that I'll be focused on are referral for transplantation, the transplant evaluation process, and the listing decision. This is a very nice graphic that has adapted the Institute of Medicine's graphic related to disparities and differences, where disparities are the morally laden gap between health outcomes or access to healthcare, and the differences are the non-morally laden gap. So you can see that the differences are really related to biologic variations or hereditary based interactions in this instance here applied to kidney disease, where we are focused on the disparities. So the socially based gap in either health outcomes or access to health care. And within that, I'll focus today on the last three categories here: broader institutional based discrimination, biases, and prejudice. Discrimination that stems from structural factors such as residential segregation or economic injustice, the operation of healthcare systems, so the different hurdles that patients have to jump through, and then discrimination in the interaction, the interpersonal communication that occurs in transplant evaluations. So in thinking about our transplant system, about all of the wonderful work that has been done and the efforts over the past 30 years to try to mitigate health disparities, it occurred to me that, this quote came to mind, that every system is perfectly designed to achieve exactly the results that it gets. And it seems that our system is receiving results of significant disparities by socioeconomic status, race, gender, disability status, et cetera. And that really begged the question to me, how should the transplant center be redesigned to achieve a different, more equitable outcome? So if that were our primary goal, to think about the design of our healthcare system, or of our transplant system within the healthcare system that we operate in, how might we redesign it to reduce disparities if that were our primary goal? So one of the main factors that came to mind at the beginning of our inquiry and thinking about, again, these social criteria, these structural based factors and how they get baked into transplant evaluation and access is reliance on subjective criteria in transplant evaluations. And there's a number of reasons that clinicians rely on subjective criteria. The first is the need and focus on improving efficiency and minimizing bad outcomes. And when I say subjective criteria, I mean psychosocial criteria that are not very clearly defined at all transplant centers. The thresholds are unclear, and patients may or may not know that what the basis for meeting that particular criteria is. I will focus on social support in my talk, but there's been recent work focusing on BMI, on past history of adherence, and many other factors that I'll lay out in a moment. The second reason for reliance on subjective criteria is expertise and the belief that over time clinicians can hone and identify better patients that might benefit and patients that may do well with transplant. And the third in particular is risk aversion. So there's transplant centers are highly scrutinized. They're subject to audits for bad outcomes. And so they may become highly risk averse. And certainly in the context of a significant organ shortage, each transplant is very meaningful in terms of its potential for increasing longevity in the recipient, but also in considering the multitude of patients on the list who are waiting for organs. So what I want to do is encourage everyone to think slightly differently about transplant listing decisions. And I want to encourage us to consider that given this backdrop of persistent disparities in transplantation, we ought to thoroughly question the criteria that disproportionately pose a challenge for structurally marginalized populations. And when considering the import of life-saving treatment, in this case, transplantation, we ought to err on the side of including people who may medically benefit from transplant. So instead of, again, thinking about this restructuring of the transplant system and redesign, ethical redesign, instead of focusing primarily on utility and weighing longevity of one candidate versus another, for example, we really focus on the potential for medical benefit for each candidate. So how do subjective biases get baked into or smuggled into transplant listing decisions? The first is that the transplant listing, instead of identifying during the transplant listing process, primarily focusing on whether this particular candidate could benefit, we often may sink into kind of a default of identifying what the ideal candidate looks like and comparing the candidate before us to the ideal candidate in our mind. And subjective criteria often lack standards. They're inconsistently applied. And so they're subject to implicit bias, to these ideas that we have that I know it when I'll see it kind of thing. This is what I think an ideal candidate looks like. This candidate differs on these dimensions. And so they may not be ideal, they may be riskier. And these decisions and biases are not always transparent to patients, and they're not evidence-based. And moreover, they may not always be transparent to us as clinicians as well. There are also ethical concerns with using subjective criteria in transplantation. The first is that they introduce disparities in the patient experience, both between centers and within a center between patients. So because different clinicians have different ideas of what this ideal candidate looks like, and because the thresholds are unclear, no two patients may have the exact same experience in being evaluated, for example, on social support or other dimensions. The second is that they tend to include social value judgments. In this case, what I mean is trying to identify a candidate by thinking about, how much will transplant improve their quality of life? How much would they appreciate transplantation? How much would they value the transplant? And that may introduce some of our subjective judgments about, for example, a person with disabilities whose quality of life may not reach the same level normatively as somebody who does not currently have disabilities. However, the improvement in their quality of life from transplant is still significant. So again, thinking about the frame shift instead of focusing on a comparison, focusing on the potential for medical benefit, for example, for patients with disabilities. And finally, as I said, this introduces disparities in access to transplantation or cements disparities in access to transplantation for certain groups of patients. Recently, I just want to call your attention. Some of you may be well aware that the OBTN board recently approved a revision to an existing paper, which is the paper that examines general considerations in the assessment of transplant candidates. And this paper examines use of psychosocial non-medical criteria in listing decisions and raises ethical concerns with a number of criteria. And the ethical concerns fall into 5 categories. The first is really the lack of clear standards and thresholds. The second is the likelihood that this lack of thresholds leads to inconsistent distribution of benefit or inconsistent access to transplantation, as I just said. Undermines respect and concern for individuals. So as individuals are, and I'll show you some data to support this, are less likely to understand the thresholds by which they're being evaluated. Their autonomy is compromised in terms of their ability to make decisions and advocate for themselves. These criteria are susceptible to stereotyping and value judgments, and they're not transparent to patients. And the white paper considered 7 factors: life expectancy, potentially injurious behaviors, adherence, repeat transplantation, incarceration status, immigration status, and social support. And these factors were chosen largely because they are commonly used in transplant evaluations in the United States, and they have been there's significant evidence to demonstrate that they may be used inconsistently and they may be subjective. So thinking again, just for a moment, turning to what we mean by implicit bias, what we mean by using subjective criteria. When we make decisions, listing decisions, evaluation decisions, really any decision, we as humans often rely on heuristics to make quick decisions or to make consistent decisions. And these heuristics are simplified cognitive strategies used to save time and improve efficiency. And they allow decision makers to make acceptable deductions. It's a shortcut in many ways. And while relying on heuristics is very important in things like the decision making that we do in daily life, in addition to driving and other decisions that we make quickly, psychologists have often kind of divided the reliance on bias and heuristics in decision making into 2 systems. The first system, cognitive systems in which we make decisions. The first system in which we make decisions, in which we are heavily reliant on biases and heuristics, is system 1. And this type of decision making is fast, it can be unconscious, it can be automated. We use it often in everyday decisions, and it's more error prone. And the idea here is really this: I know it when I see it. We use this in driving, we use this in grocery decisions, we use this in decisions where we have to make fast decisions, and we are experts in this type of decision making, right? We've made this decision many, many times before, and so it is fairly automated. The second type of decision is slow. It is a deliberative decision-making process. It is a conscious decision-making process. It's effortful. It involves complex decisions, and it is more reliable. It is not free from bias, but it is less reliant on biases and heuristics. And what I posit here is that we really want to focus on shifting transplant listing decisions away from system one and really focus on how we can integrate slow, deliberative, conscious, effortful processing in transplant listing decisions, and reducing use of subjective criteria. Subjective criteria oftentimes rely on system one thinking. So fast, unconscious, the processing of what someone feels like. Do they look ideal? Like how are we assessing their social support? And in turn, slow it down and evaluate what are the types of assumptions that are baked into this evaluation process. This is a wonderful article that was published last year that demonstrates that these cognitive biases are common in surgery, not just in transplantation decisions. And here, the authors point to a number of cognitive bias, attentional bias. So here the quote is, she has some topical oils hoping that it would all go away, right? And the idea is here that the focus is on some side factor, and you're making an assumption that this person has, unrealistic expectations of their surgery and of their outcomes. Other types of biases that are common in surgery, and our group has found in transplant decisions as well, is anchoring bias, which is an over-reliance on the first piece of data that you come into contact with. So here, the example is around this Mrs. Smith, who is an anxious young person with a new diagnosis of Wright breast invasive ductal carcinoma. And this over-reliance on this first piece of information shifts the way that the subsequent discussion of listing decisions, for example, might go. So if somebody says, this person showed up with their whole family, they're very dedicated, the family is really supportive of our patient, that over-reliance may cause you to believe that this person is a stronger transplant candidate than if somebody came in and said, this person showed up by themselves, their family was unable to make it to the transplant evaluations, et cetera. And I'll show you some examples from our qualitative studies about this. Focus on unconscious bias and implicit bias in surgical decision-making is not new, although it's new to transplant. It has been demonstrated in acute care surgery and among different groups of surgeons as well. So turning to social support, again, as the example here, I want to identify how social support can smuggle in these social value judgments. So again, social support, thinking about how somebody is presenting to you with their family, assessing the quality of their relationships and their social structure, raises questions about the deservingness of the candidate, the likability of the candidate. And this is a quote from a large qualitative study that we've completed with transplant clinicians, where one transplant clinician, when asked what is the most important or predictive variable for transplant success, told us, I say, the most important variable, if someone is going to do well after transplant, is does someone love them? This really raised a lot of questions for our team in terms of kind of how would one really assess how loved somebody is, and what is the evidence base to support that? Just to back up a moment, our team in beginning to evaluate social support and its use in transplantation started off by trying to identify whether there was an evidence base to support the use of social support. There is a wonderfully large and robust literature demonstrating that social support is associated with quality of life following transplantation. But we were really in our interviews hearing about social support as a marker of graft failure, social support as a marker of adherence. And so we conducted a systematic review and meta-analysis of all published studies, which included 32 studies and over 9,000 participants. And we assessed to see whether or not social support or marital status, which is often used as a proxy for social support in the United States, were predictive of medication adherence or outcomes. graft failure, survival post-transplant. And what we found is that marital status was not significantly associated with transplant success in any of the published literature, and social support was very weakly and inconsistently associated with post-transplant adherence and outcomes. So not statistically significant and not overwhelming. The studies were of largely poor to poorer quality. They were observational studies. And they are, of course, subject to selection bias because social support is so frequently used in transplant decisions. Nonetheless, given that this is a criteria that's used to exclude patients, we wanted to focus and understand what the evidence base supporting that was. And indeed, we found that it was uneven at best. So next, our team looked to see how important is social support to transplant clinicians. And it could be our team at the outset was not sure really if transplant clinicians are reliant on social support in making a final transplant decision or a listing decision. And so for yourselves at home, you can consider, how important compared to these other factors in this table, how important do you think that social support is to transplant clinicians in determining eligibility? Would it be the second most important factor or the fifth most important factor or the least important factor compared to life expectancy with transplant, quality of life with transplant, time on the waiting list, life expectancy without transplant, adherence to medical regimen, or age? And to assess this, we conducted a survey of over 600 transplant clinicians in the US. We conducted a discrete choice experiment, which allows you to essentially creates a whole bunch of comparisons, different patients with different attributes. It varies the attributes and asks the participant to select which candidate should receive the transplant. And based on the choices, so each person completes, I think, five vignettes. And based on the aggregation of all of these choices, we can identify what are the most important attributes overall. So in this study, depending on kind of what you thought, if you guessed that it was the second or third most important attribute, you would be correct. So compared to the other factors that I've just described, social support was the second most important factor after life expectancy with transplant and adherence, which were tied for first. And what was really interesting to our group was that the conditional importance of social support varied based on your ethical beliefs. So for people who believe that social support listing is fair, we asked questions about fairness and about utility and about the potential for disparate outcomes. So the fact that we asked clinicians, participants, if they believe that social support was equally easy for patients who had low and high socioeconomic status to demonstrate, and they disagreed with that overwhelmingly. And so you can see that among clinicians who believed that social support is important to avoid organ waste or otherwise adopted a utilitarian mindset, utilitarian beliefs here, social support was the most important factor. And those who believe that social support undermines fairness in listing were less likely to use social support, were less likely to view it as important in the listing process. What else did we learn from our study? So we had no priors about kind of how many patients or what percentage of patients might be affected by social support. And we learned that across over 200 transplant centers in the US, on average, 10% of patients who present to transplant centers, so again, thinking of the funnel, those that make it past that first stage of the funnel to referral and initiate the evaluation, 10% of those patients are not listed for transplant because of their viewed to be inadequate social support. And we asked clinicians if they had ever prevented a patient, social support had ever prevented a patient from being listed at their center. 43% said that yes, primarily it was social support that was used to prevent patients from being listed at a center. And 44% said that social support was used in tandem with other criteria. So overwhelmingly, a large percent, most clinicians had used social support in excluding transplant patients. So to interrogate again, what work social support was doing, how it's used, why it's used in transplant decisions, we conducted a study that from this sample, we drew a purposive sample of 45 transplant clinicians from 34 centers of varying sizes and regions. And we interviewed transplant surgeons, social workers, and nurses, as well as nephrologists, hepatologists, pulmonologists. And we asked them to explain their response in the survey and to explain the use of social support. And I'll just show you some of the quotes here to illustrate the challenges that some populations may have and the ways in which using a subjective criteria increases susceptibility to bias and inconsistency. So when asked about use of social support, respondents said things like, I wouldn't say it's evidence-based. I think it's just everyone's experience. Another said, it's very subjective. It's kind of like an art. Another said, we don't have hard criteria. It's mostly an assessment by very experienced social workers, clinical judgment more than a particular set of criteria. And finally, one had told us, it's kind of like the definition of pornography. You know it when you see it. So thinking about that, we probed further to understand, whether clinicians thought that using social support was evidence-based. One transplant surgeon really drew upon the importance of anecdotes, his own and at other centers. And they make these cognitive leaps around, what is the root cause during poor outcomes. So this transplant surgeon said, I think it's part of just a combination of learning from mistakes. An important proportion of adverse outcomes can be traced back in some way to social support, or social support has changed. And he went further to say that he's certain that there is room for more robust analysis of the importance of social support, but every program has anecdotal stories of patients who have had a successful transplant, but ultimately failed because of lack of follow through on the far side of getting a transplant. So here again, thinking about the table and the cognitive biases, you can see that there is a focus on social support that is owing to the saliency of these anecdotes, but not necessarily the robustness of the evidence. Others said, I've never really looked at the data, or it's hard to find a lot of consistent evidence, but there's so much anecdotal evidence to support it. And finally, one nephrologist told us that it was a good question to ask about evidence-based medicine. He says, I'm not sure we have any evidence, to be quite honest. There's not literature. I've not seen literature. I've not looked, so I don't know whether it exists. Shifting, so again, focusing that these criteria have the potential to be used inconsistently. They may or not be supported by evidence, and they call upon our instincts and introduce value judgments. So I'll give you some examples of that. So a social worker said to us that part of the difficulty making these recommendations is just to make sure that they would, quote, withstand a test in terms of this meaning this evaluation isn't pure instinct. A kidney transplant surgeon said to us, maybe in the beginning I felt conflicted, but I think at this point I'm a little desensitized. So this idea that you become desensitized, you become more expert in your judgments, and it may become more automated, your use of social support and your reliance on your instinct. A heart and lung surgeon said to us about patients, you can make an argument that there are patients that have social support or have support, but other circumstances would mitigate against them ever being an independent, productive member of society. Productive doesn't mean that they're working, paying taxes, just having led a life overall that you think, even they are during their retirement years, deserves at that point to lean back and enjoy their grandkids. My feelings about not transplanting people who don't have social support is no different than my issue about people who I think have a high chance of going back to smoking cigarettes or going back to crystal meth or heroin. So you can see in this quote, which may be particularly troubling, is that this idea of social support is somehow getting merged with having a productive life, having a life that is deserving, a person that is deserving to lean back and enjoy their grandkids. Okay, so as we're coming to the second half and the end of this this presentation, I want to call your attention to the focus here of clinicians as gatekeepers. And one proposition that I want to make is that much of the implicit bias that is included in transplantation is a result of clinicians acting as gatekeepers and being conflicted when acting as a gatekeeper for the organ, as opposed to really focusing on the medical benefit of the particular patient in front of them. And so here you can see these are two social workers who describe that you're an advocate for your patient as much as you're a guardian of the organ, which I'm sure if the patient in front of them would know that is highly concerning. Another social worker said, we talk all the time about advocating for the patient versus advocating for the list and the scarce resource and advocating for the donor family or the deceased person who chose to donate. So again, thinking about whether clinicians are focusing on the medical benefit, or are they called upon to focus on all of these competing interests, and at that point are more reliant on system one quick decision making and their kind of gut intuition about the potential for this patient to benefit. So here are some examples of clinicians who were not acting as gatekeepers, did not see their role, and they presented a very different use of social support. So one transplant surgeon said, kidneys are a societal resource. They are not my resource. It's not my job to be a gatekeeper on that. If someone wants a transplant, they fulfill all of what we consider reasonable criteria to get them on the list. It's my job to make them a reasonable donor recipient match to get them a kidney. Another nephrologist said, it's really about the fiduciary responsibility to get the patient the best graft possible that lasts the longest for that individual. It's the best decision for that particular patient. So eschewing kind of the societal responsibility and really focusing on their particular obligations to the patient. Progress is possible, but it's difficult. So we learned from some centers who did not rely on the social support criteria, again, comparing centers that excluded a high percentage of patients owing to social support to those that excluded very few patients or none at all. And they said in the first few years, they described the evolution of the social support criterion at their center. And they say in the first few years, they had just about as many denials as acceptances. But then they looked at their outcomes. They did a few poster presentations, and they saw that, they say, we saw that the numbers stayed the same even as we were loosening some of our guidelines. And in fact, it's extremely loose now, and the numbers are even better. But that involves a lot of participation from our teams, our physicians, our hepatologists, and some of the relationships we've forged with rehab centers in getting these patients engaged. So again, highlighting the structural disparities and the role of structural and institutional and societal factors in getting to an equitable transplant system. For the sake of time, I'm just going to jump ahead a little bit, and I can go back and talk a little bit more about kind of the evaluation process, but I want to move ahead and think about ethical redesign. So back to our question from the outset of this presentation, how should the transplant center system be designed or redesigned to achieve a different, more equitable outcome? So this involves shifting from a utilitarian mindset, really heavily focused on achieving the best possible outcomes, to focusing on health equity as a primary outcome. And I think that in the context of COVID and COVID vaccinations, much of this type of thinking has risen to the national level for health policy decisions. And in the US, and I don't know the Canadian example as well, but would hope to hear from you. There's a lot of focus on trying to distribute vaccines equitably, and even in some areas, slowing down vaccine distribution in order to achieve more equitable access. Obviously, there are still, mountains to climb. There's a chasm by race and ethnicity and education level in terms of vaccination rates. But this was a prime example where equity was at least positioned similarly to utility in terms of a rollout of a scarce resource. And here too, we need to consider thinking about from health disparities, these are preventable differences in the burden of disease, to thinking about health equity really as being our goal. And that can be defined as when every person has the opportunity to attain his or her full health potential. So thinking again about medical benefit. And no one is disadvantaged from achieving this potential because of social position or other social determined circumstances. In the case of social support, the reasons, the structural reasons for disadvantage may be things like difficulty for patients who live in rural areas, patients with less means, to patients with more whose caregivers or whose social support have more dependence from coming in and demonstrating that they are capable, that they are committed, and moreover, our reliance on what we think of as the typical notion of family. And there's a lot of research that we've done in our lab and other social psychologists have done to look at perceptions of family that differ by race, ethnicity, and kind of how easily people are able to identify a core group of people as a family or a consistent, robust support. I'm happy to talk more about that if there are questions. So what are the keys to shift from a gatekeeping to a health equity mindset? And I would propose that there's a few key steps. First is to focus on medical benefit for the individual patient in front of you, and to use social support evaluations instead of as an exclusion criteria as a means of identifying areas for improvement or enhancement. So ways of identifying potentially patients who would benefit from additional resources. Second, to avoid medicalization of social factors. Social support, after all, is we are social creatures, as we're reminded, especially during this past year, and to avoid, the medicalization of social factors and focus on what it is that social support is doing. Is social support important for transportation? Is it important for medication sorting? Is it important for symptom monitoring? And there are certainly new technologies and ways for us to complete those specific tasks without relying on kind of the more global social support umbrella. Third is to change incentives. This is a systemic issue to reduce gatekeeping and increase reliance on evidence-based medicine. And this would include better risk adjustment for transplant centers and potential penalties for cherry picking. Next is to avoid bedside rationing decisions, which can be inconsistently applied across patients and between centers. As clinicians, to question your assumptions and interpretation of patient presentations. So if people are late for an appointment or if they miss an appointment, to think kind of more globally about the potential challenges instead of assuming that it's motivation or lack of appreciation or unreliability. And finally, to use clear, transparent, and revisable decision-making processes with clear appeals process for patients. These are some additional cognitive debiasing techniques from a paper published in 2003 in academic medicine. And a graphic on the left that just demonstrates that oftentimes, when we medicalize what are otherwise social criteria, we assign a value to them, and we think that they are more evidence-based or consistent or predictive than they may be. And ultimately, what we know about a person's life is very small compared to what their overall life is. And many of those examples came up in our qualitative research. So I will stop here just to allow some time for questions. But I think the bottom line that we've come away with, both from our studies and our experiments in our lab, as well as the recent paper and work with the OPTN, is that equity requires purposeful reframing in transplantation and setting equity as a top priority. And so with that, I will turn it over to Jed to open for questions.
Thanks, Karen, for giving us all to think about. While we're waiting for audience submitted questions, I do have one of my own.
Sure.
If your goal is to avoid unwarranted gatekeeping, have you thought about how we would identify minimum objective psychosocial criteria for listing for any particular organ?
Yeah, so it's really it's a really good question. So I think that we had one study that looked at actual listing criteria for social support and other psychosocial criteria from 168 centers. And many of them, 10% lacked a definition at all. And many of the definitions were vague. So what I would do as a first step is try to clarify, what is this criteria doing? What work is it doing? Are we focused on the potential for adherence? Are we focused on using a metric to identify the potential for patients to secure transplantation? Are we looking for monitoring of symptoms? Are we looking for well-maintained mental health, for example? And by identifying very clear criteria, Jed, as a first step, we can then, I think, articulate more clearly what the criteria should be and what the minimum threshold is that is necessary. So my work doesn't necessarily suggest that no thresholds, that we shouldn't use these criteria at all, but rather it suggests that we be very mindful and clear about what we are looking to predict, what this criteria is doing, and that it doesn't disproportionately harm patients who are already structurally marginalized.
Thank you. I'm looking at the chat window and we have a few questions. One is from Diane Godkin, who refers, I think, to the continued need to assess medical benefit, at least for the patient's own best interest. And she's asking, could you say a bit more about how medical benefit would be objectively measured?
Yeah, so I think that here it would be assessed just in the same way that we assess it in transplant candidates where we are not worried about their social support. And so that would be things like relief of symptoms, increase in longevity, the potential self-perceived benefit for quality of life as viewed by the patient. Those would be the kind of the key areas that I would consider in considering medical benefit.
Okay, and Cynthia Cien is asking, is there data in public universal healthcare systems such as Canada or the UK? I would actually elaborate on that a little if I may take the prerogative as moderator and ask, the US has seen fairly recently substantial health insurance reform in the form of the implementation of the Affordable Care Act. Has that illuminated anything about what sorts of inequalities are driven by insurance and what inequalities in access to transplant fundamentally have other causes?
Mm-hmm. That's a great question, and I think we all had very high hopes and are very grateful for the Affordable Care Act and the monumental changes that it's made for many patients in terms of their ability to access transplantation. But I will say that there still is a gap, and there are still persistent disparities that exist for reasons just as the ones that I've described today, that have very little to do with insurance. So even within kidney transplant in the United States, kidney transplant has always been covered by Medicare for all ages. We continue to see these disparities in access, and I think that they I don't know the data for Canada or the UK as well, although I do know that in Canada they considered, and I think have removed social support as an absolute contraindication and use it as a relative contraindication. But I would say here that although insurance poses a challenge that is surmountable with insurance reform, it is not sufficient, necessary but not sufficient to overcome disparities in access to care.
Thanks. Looking through the questions, there is one from Diego asking if you could say a little more about the scientific evidence or lack thereof linking negative outcomes to social support.
Yeah, Diego, it's a great question. So as I said, when we embarked on this, we looked at all of the published literature that we could find that evaluated social support in any form, any definition of social support, and adherence outcomes or survival or graft survival outcomes. And the truth of the matter is that there's just not a lot of data out there. It's difficult to study because in a lot of places it is a requirement. And so finding patients who do not have social support is challenging. There's quite a selection bias. On the other hand, there are certainly cases where patients do not have social support. Either a transplant center does not use it in their listing decisions, or it may be an emergency transplant or other circumstances in which social support was not used. From the published scientific evidence, peer-reviewed evidence, there is very little association between social support and adherence or survival. That's not to say that if the study qualities were better, we wouldn't find an association. But currently there's not one that's well understood. The second point that I would make is that even if there is an association in the future in some excellent, better quality studies than the ones that we had access to, one should still think and balance, whether or not the improvement in utility is worth the persistent gap in equity. And what I would urge everyone to think about, again, with ethical redesign, is to think about the use of these criteria preclude many patients from ever being listed, from ever accessing life-saving transplant. And so in thinking about that, considering, what bar of evidence should we be using when making that type of decision?
And the questions are coming in fast right now. I'm going to have to pull them as time is running short. One that would be interesting that a member of our bioethics program, Claudia Barnard, has asked is, can you say anything about how conceptualizations of social support might differ by race and or ethnicity, and how this has impacted evaluation?
Yeah. So the reason that we've looked at this is that there is a tremendous literature in social psychology and in sociology looking at different family structures by race. And so in the US, Black people are less likely to be married. They're more likely to have diverse networks. So they're more likely to present with social support members who are not necessarily a daughter or a husband or a son, an immediate family member. They may present with members of their church, with coworkers. They may, in other family structures by race, ethnicity also vary. And there's been also significant work, including by our own group, using social relationships, different social relationships, and assessing implicit bias in the evaluation of how robust an association is. So in one experiment, for example, in our lab, we asked people, we presented similar vignettes, identical vignettes, and varied only the relationship of the person. So for one, they were a spouse, for one, they were an ex-spouse, for one, they were a friend, for one, they were a neighbor. And as the relationships changed, even though the commitment was there and the presentation was identical, that clinicians perceived the robustness of the relationship to be less. There's also a tremendous literature just on the ability for people to recognize a family unit when a family is same sex or different races. That I think also plays into kind of this just snap judgment about how likely it is that, you know, this social support is our ideal or meets our minimum threshold.
And Carolyn Tate is asking a somewhat related question about whether this focus on equity is robust enough to address populations such as Indigenous people in North America who have been affected by historical oppression or colonization in a way that has impacts across healthcare delivery and the continuum of the life cycle. Is there anything you might say about either the structure of transplant medicine or what transplant centers might do with reference to these disparities that begin affecting that funnel long before the patient is actually listed for transplant?
Yeah, that's a terrific question, and I will say that you know, all of the work that we've done in our lab, especially on social support, really calls or shines a bright light on the importance of social workers and also the tremendously difficult predicament that they're in trying to, you know, deal with all of these upstream complex structural barriers while ensuring that there's going to be good outcomes and that the patients can adhere to treatment post-operatively. And so I guess just as a first comment, I would just want to make the point that this is by no means any judgment on workers who are heroic in their efforts to support patients. This is rather, my hope is to identify the conflicting role that social workers are in trying to both respond to the needs of patients who are structurally marginalized and to gatekeep at the same time. And so, Jed, to your question, I think that identifying, using the social support evaluation to identify what are the gaps, and then really thinking creatively. There's a number of new interventions in the US related to, at some transplant programs, related to transportation, related to housing near a transplant center to reduce barriers to access. And I think that in Canada as well, you and I have talked that focusing on those may reduce some of the geographic barriers and some of the barriers for Indigenous populations as well. But again, really identifying what is the concern. Is the concern transport? Is the concern medication management? Is the concern, instead of lumping it into a giant category of social support, makes it more identifiable and easier to target.
Thanks. That question and the acknowledgement of the possibility of role conflict is something that this lecture's namesake, Linda Wright, would be very interested in. We have time for one more question, and so I'm going to field one from Laurie McDonald, who works in our lung transplant program, where I think it's fair to say there is a strong belief that social supports are especially important. She asks, as a social worker, one may work with patients to try to optimize them for transplant and close some of these gaps, like finding transportation assistance, but it's very difficult as a clinician to find a substitute for around-the-clock observation and assistance in the rocky first few months after transplant. What would you suggest that a lung patient with no supports or no formal recognized supports do? And for that matter, what would you suggest that a clinical team do in that situation to optimize the patient or otherwise figure out what we're able to help them with?
Yeah. So in the case of lung transplant, it certainly was the group that had the highest demands on social support of all of the organ categories that we looked at. And I would say that even in lung transplant, in our survey, there is tremendous heterogeneity. between some transplant centers requiring 2 full-time caregivers in perpetuity forever, whereas others required a single caregiver for a period of 2 months, whereas others required it 6 to 8 weeks, and others required it for 6 months. So I would say first identifying what the minimum threshold is very important in helping people with challenges meet that threshold. The second point that I would make is that some centers have increasingly grown reliant on paid formal caregiving as opposed to informal caregiving. Interestingly, other centers exclude paid caregivers because they feel that they don't provide the motivation that is needed for patients. But in an effort to reduce disparities, I think growing attention to the minimum demands of caregiving and assessing, whether and how those could be supported by either rehabilitation centers or paid caregiving for patients who do not have an alternate option is an important first step.
I think there's some room for optimism in that.
Yeah.
On that note, I'm going to metaphorically turn the mic over to Dr. Tsien to close us out.
Thank you so much, Keren and Jed. That was really an excellent talk. And I think everyone, as we can see in the comments, really enjoyed it. This is our last talk for the year, for the academic year. We'll be